Hello, and welcome to HQI Stopping Sepsis in Virginia Hospitals and Nursing Homes conference call. My name is Jason, and I will be your operator. At this time, all participants are in a listen-only mode. Later, we will conduct several question-and-answer sessions. And please note this conference is being recorded. I will now turn the call over to Deb Smith. You may begin.
Thank you, Jason. And good morning, everyone. Thank you for joining HQI's Stopping Sepsis in Virginia Hospitals and Nursing Homes webinar. As Jason said, my name is Deb Smith. I'm one of the improvement consultants at HQI working with the nursing homes in this project. I just want to remind you all that your lines are on mute until any of the question and answer periods, which then you'll be prompted on how to get into the question queue. Please be as attentive as possible to this webinar presentation so that we can all get as much information from the webinar and our peers as possible. But we do understand competing priorities, so this webinar is being recorded for future viewing. Today's objectives are to we'll be reviewing patient-family engagement, and we're also going to have a really wonderful patient story that's inspiring. I hope you all enjoy that. We're going to review hospital and nursing home baseline data review. And as always, we're going to make sure that we leave plenty of time for your questions and comments at the end and during the webinar after the data review. But at any time at all, please type questions into chat because we have Wanda Clevenger and Candy Hamner who will be monitoring the chat as we go. So you can type your questions in there. It's a virtual world, so I always like to include our pictures, much as I hate to see my own. But I just want you all to, have a bit of an idea of who you're working with. So from HQI, I'm Deb Smith, and I'm the lead of the Virginia Nursing Home Project. Candy Hamner is leading the Maryland project. And then from VHHA, working with the hospitals, we have Betsy Archer and Wanda Clevenger. We also have a whole team working with the nursing homes at HQI. So Sheila, Teresa, Lisa, and Allison all work with the Nursing Home Improvement Network. So many of you probably work with them also. So I'm going to turn the program over right now to Sheila McLean, one of the vice presidents at HQI. And she's going to talk to you a little bit about this patient story that we have for you today. So Sheila, the floor is yours.
Thank you, Deb, and good morning, everyone. It's my honor to share Mr. Reginald Tom's story today. I did not have the personal pleasure of meeting Mr. Tom, but I do know his daughter, Alicia, and I know her love for her dad. You see pictures here of Mr. Tom and his family. Alicia shared these pictures with purpose. You can see an early picture of his daughter, Alicia, and him at her high school graduation in the top left corner. Alicia shared with me that Mr. Tom loved to sing. He was a very dignified gentleman, and he was the life of the party. In the summer of 2012, Mr. Tom went into a coma due to complications related to diabetes. Alicia and her family were elated when he awoke from this coma. Knowing that he would need rehabilitation and skilled care, with open arms, Alicia's home, friends, and then employer immediately offered him a bed. See, Alicia is a nurse and had been employed at the time as a clinical education director at a skilled nursing facility where she had worked for many years. The doctor said that it would take about a year to truly see how Mr. Thomas would progress neurologically. So the family celebrated the day he stood in therapy and took those steps that you see in the top right-hand corner. Alicia recalls that she had tears of joy that day. Mr. Tom had a PEG tube, he was diabetic, he had C. diff, and was underweight. The facility cared for him, and they cared for Alicia and his family. Alicia stopped being that overbearing family member who wanted to see every single blood sugar and every lab result. She shared that she let go because she trusted. She trained the nurses on the importance of contacting a physician to inform them of abnormal lab results, the importance of monitoring and following up, and the importance of communication between the nursing assistant and the nurse, and between the nurse and the physician to ensure that the patient receives the care that they needed. But somehow, Alicia found herself once again in the ICU with her dad. She was told that Mr. Tom had an infection, which had initially been a UTI. It had been untreated, and he had now had a serious systemic infection. The doctor said sepsis. The doctor said this word that Alicia herself, as a nurse, had used many times. Alicia discovered that the infection had gone untreated because Mr. Tom's lab report had not been reported or faxed to his doctor at the nursing facility. The doctor at the hospital wanted to know how this went unnoticed and how the family wanted to pursue this, how Alicia felt about it, how the facility didn't see the signs of infection, how they didn't communicate this to the physician. All of these questions came at her and overwhelmed her. Alicia found herself at a crossroads. How did she defend her facility, her nurses? She saw them as her nurses. She trained these nurses, while at the same time get justice for her father and her family who wanted answers. She chose the facility. She trained these nurses. She had checked their work. She had conducted nursing boot camp training. She had let go of being an overbearing family member. They had said no need to micromanage their care. They said she could sleep at night. Subsequently, during the hospital stay, Mr. Tom got better and the family celebrated. He returned to the facility on antibiotics and with strict supervision of every aspect of the care. About 3 or 4 days afterwards, Alicia began to let go a little bit because Mr. Tom was responding. He was getting better. He could be found sitting in the hallway, laughing with the others, even though he tired easily. Days progressed, and the nursing staff missed a day of vital signs. But she gave them the benefit of the doubt. She worked with them to remind them of the importance of taking vital signs, and especially while someone was on antibiotics. Alicia had promised her dad while he was in a coma that if he would just wake up, she would take him to the Al Green concert on September 5th, 2012. The day of the concert comes, and Mr. Tom is able to attend. You can see the picture in the center is of Mr. Tom and his wife, and the one of he and Alicia in the bottom left. Alicia shared that she brought him that hat and shirt especially for the concert. Sadly, Mr. Tom never cleared the infection. The picture that you see in the bottom middle is September the 11th, 2012, and he passed away in that bed, in that position, at 2 a.m. on September the 12th. The next day, Alicia received a piece of paper. She saw the word again, sepsis. The doctor had written sepsis. Alicia knew how hard it was to forgive someone. She never knew how hard it was to forgive someone until she stood there and looked at the nurses who did not notify the doctor of the lab findings, as she looked at the CNA who didn't get the vital sign, the final vital sign, who didn't report the change. But she did forgive. They were also the people who loved Alicia and who loved Mr. Tom. They were good people, but they made mistakes. Alicia is still a nurse. She owns her own company and now teaches. When she teaches people about infection prevention, it is personal. It is important. She teaches it as part of her curriculum, like it was last time she ever gets to say something to someone who is going to take care of her father. It might be your patient. It might be someone in your hospital or someone in your facility. But to someone else, it's the person who should have walked them down the aisle. Mr. Toms was not there to do that for Alesia. Alesia loves her father and loves her job, and she continues to advocate and always gives time to contribute any resource that she has to teach others on how to provide quality care, how to use the CN Sepsis 100 resources to their benefit, to care for patients and give them a quality, long-lasting life. As you can imagine, this is an emotional story for the Toms family, and I truly appreciate the opportunity and the privilege that she gave me today to share it with you. Thank you.
Thank you, Sheila. That's a powerful story. And I have not met Alesia, but I'm extremely impressed with her ability to move through her pain and loss and make something positive of it. Many people wouldn't be able to do that. If you have any comments about the story or maybe some stories of your own, the chat box is open. We'd like to hear from you, because the reason why we're doing all this work is because of stories like this. And I know that we all have, our own contacts and our own stories, whether they're personal or one of our patients or residents, that we've seen this type of thing. So I really appreciate it, Sheila. Thank you for sharing. I'd now like to turn the floor over for a short time to Amy Lentz. Amy Lentz is the Integration Program Manager at HQI, but she's also the lead of the HQI Patient and Family Advisory Council, and that is a great little council that is doing lots of work. They're very active, very engaged. So, Amy, the floor is yours.
Great. Thank you, Deb. So glad to be here today and share a little bit about HQI's Patient and Family Advisory Council. As an organization, HQI understands the importance and value of engaging patients and family members in our work. But initially, we struggled a little bit on what was the best way to involve patients on our various teams and projects. So we decided to form a council to really create a formal structure to engage patients in our work. So I briefly just explain how we got started. Most importantly, we obtain our leadership support. And what I mean by that is not only ensuring they agreed with forming the council, which they did, but to make sure they really understood the level of resources that we would need to form and support the council. I'd say the first few months we had to invest quite a bit of time. We quickly realized it wasn't the job of one person. So we formed a dedicated planning committee, which includes myself and 5 other team members. We also have an executive sponsor who is our chief operating officer that I was communicating with on a weekly basis, mostly giving her updates and letting her know if there were any challenges or barriers as we got started. As a planning committee, we created a recruitment plan. We developed materials, recruitment flyers, as well as an advisor application form. As a planning committee, we work with our entire company and external organizations to distribute those recruitment materials. Then we had follow-up phone screens with individuals that were interested in volunteering, and that really helped us to identify what areas the individuals were interested in and see if they would be a good fit with our organization. We also created a vision and a charter for the council, and those 2 documents are very important. It really outlines the scope of the council, as well as the commitment and expectations of our advisors. It's also the planning committee members' role to keep our council visible, so we're consistently communicating with others in our organization, letting them know what our advisors are working on. We also work across the organization to identify different projects to involve our advisors in. And we also want to make sure that we're sharing with providers such as you, giving everyone updates on what our council is doing. Our planning committee also created an orientation program, which includes an overview of HQI, describes who we are, what we do. We also talk about our various projects. We describe what quality improvement is. And then during that time, during the orientation, we also discuss the roles and expectations of advisors. And finally, our committee continues to support with planning those council meetings and involvement with our advisors. Deb, you can go to the next slide, please. So after months of preparing and recruiting, we held our first meeting in April of 2016. So we are coming up on our 1-year mark. Our council includes 12 advisors. Some are pictured here as well as on my next slide. And just to give you an idea of their background, we have one who is a former social worker. We have a couple that are nurses, a couple that are caregivers, a retired Navy admiral, a retired teacher, as well as a psychologist. The council meets every other month for 2 hours. Some of the advisors meet at our office in Richmond, Virginia. Other advisors join us virtually over the phone and webinar. In those first few meetings, we built rapport and took the time to establish trust and build relationship. None of them knew who HQI was, so they were new to understanding our work, but they didn't know one another either. So it did take some time just to, again, make sure everyone was comfortable in building that relationship. Each meeting, we usually provide an overview of a topic. We ask the advisors to share their experience. We discuss the topic as a group. From there, we identify common themes, and then we see who has experience or interest in working more in depth with the HQI team. So, for example, tomorrow we have a council meeting, and Deb Smith is going to provide an overview of this sepsis project. She's going to explain sepsis, share some of the resources, and then we'll ask advisors to share their personal experience and provide on ideas on ways we as a group, including yourselves, can improve the awareness about sepsis with patients and caregivers. And again, we're hoping after tomorrow's discussion, if someone does have, expresses a lot of interest in, getting more involved with the project, we'll include them to our internal sepsis planning committee meetings as well as webinars with you all. In between meetings, our advisors participate in various activities. Quite a few of them review patient-family materials. In fact, we'll talk about one today that they provided feedback on. We also have several advisors participate in a panel discussion with our board of directors, and then others have participated on national webinars. Deb, you can go to the next slide, please. Thank you. And I could go on, but for sake of time, I'll just end by providing a few key insights. I'll just mention it does take time, especially at the front end, at that planning phase and recruitment, but I gotta tell you, it's really worth it. It's also important to create awareness of the council and make sure everyone in your organization is aware of its purpose, so everyone on your team is engaged in collaborating with advisors. Again, you want to allocate resources. So you either have a planning committee or designated individuals to communicate with advisors, to plan those meetings, and organize and plan activities. Most importantly, I would say be flexible. Recognize you do not need to have all the answers. I think this was our biggest lesson learned. Forming the Patient Family Advisory Council was new to us, so we tried to make everything perfect, and sometimes that's what got us stuck. So I just encourage you to be transparent with the individuals. Let them know this is new to you and that you welcome feedback. It's been great once we got started. Like I said, we just tell them it's new and they move forward with us. Also, I'd say recruit the right individuals and you'll get the ideas and results. So when you're getting started, really think about the qualities and skills you're looking for in advisors. We recruited individuals that can share their personal experiences in ways that we can learn from them. We also wanted someone that could listen and hear other points of view, as well as connect with people. And we really wanted someone that could see the picture and represent patients and families from their community. So I will end there, and I think we're going to take questions at the end. But I'll also provide my contact information, so if anyone wants to talk in more detail, I'd be happy to do so.
Thank you, Amy. I think we're doing pretty well with time. So, Jason, can you let everyone know how they can get into the queue to ask questions? Because I think this is a great time to just take a minute and see if there's any questions about our Patient Family Advisory Council, or the patient story that we heard earlier. I mean, I'm still kind of emotional over that myself. So, Jason?
Thank you. If you'd like to ask an audio question, please press star then 1 on your touch-tone phone. If you wish to remove yourself from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you'd like to ask an audio question, please press star then 1 on your touch-tone phone.
So while we're waiting for that, Amy, thank you for being here. And you can stay for just a couple minutes right now in case there's any questions, right?
Yes, I'll be happy to stay throughout the session, Deb.
Do we have anybody in queue?
I'm not seeing anyone at the moment. Once again, if you have a question, please press star 1.
You can also write your comments in the chat box, but I'm curious how many of the facilities out there have their own advisory council for patients and families? Is there anyone that'd like to talk about that? All right, it's a quiet group, I guess. Jason, no one in queue?
No one has queued up at this time.
Okay, well, thank you. Then we will move forward. Thank you, Amy. So now I'd like to turn the floor over to Candy Hamner. As I said before, Candy's been leading this work in Maryland for over a year. So they're a little bit more advanced than what the Virginia group is right now. And it's really great because we've been able to use a lot of the patient and family, resident and family tools that they developed. In fact, I hope everybody received their tools. If you're a nursing home, we did mailed, as in snail mailed out, the beginning of the toolkit for you. So anyone who hasn't received that, please let us know in chat and we'll check into that. So Candy, the floor is yours.
Okay, so thank you, Deb. What you have here is just a snapshot of the first page of the Resident and Family Education Guide that we developed in the Maryland group and has been revised and been handed out or will be handed out to all of you both as a nursing home guide as well as a hospital guide. And the reason we developed this was really to reach out and begin the awareness and education to residents and families about sepsis. Most of you know that there's not a lot of public knowledge about sepsis. And one of the ways we're going to wrap our arms around sepsis is really to be able to get the public to better understand the potential signs and symptoms and begin to understand what it is. So we developed this guide. We put it in simple layman's terms. We've actually had the council that Amy Lentz spoke of review the guide and provide some comments back to us that we incorporated into it. But the purpose being simple language, simple explanations to help people, non-clinical people, begin to understand what sepsis is. And we initially had it in Maryland for it to be presented at a resident family council meeting to help them begin to understand. However, I found out that people in Maryland are very creative and inventive to nursing home leadership, and they found a lot of different ways to utilize this guide. Next page. Next slide. So I put this up as a joke, 101 uses for the guide, but I imagine we could come up with close to that number. Again, while I said it was created to educate residents and families at a family council meeting, some of the things that people in Maryland have used it for you might find very useful. One, when one of our facilities, when they had a family member come in and the resident had been transferred to the acute hospital for possible sepsis, the family member had a lot of questions. They also gave them the guide to take home so they had something that they could look at, and answer questions or help them formulate questions. Another of the facilities, actually, I think probably a lot of you may have in the area where visitors may sit around in a nursing home or relax. They have brochures. Some of the nursing homes actually placed it there just for general education and awareness. Next slide. Another thing that it can be used for is not just to educate family members and public, but also to educate the non-clinical folks in your staff or in at your board meetings. So what they've done is at management team meetings, leadership meeting, whatever you might call that meeting, they have utilized it there. It's also been given out at a health fair, just as a handout. New employee orientation, again, general for the non-clinical staff, and also for a board meeting to educate the board members. I'm sure you could come up with a lot of other uses for it, but it's an excellent guide, and I hope you will utilize it throughout your facility and help spread awareness of sepsis throughout the public. Thank you, Deb.
Thank you, Candy. I did put in chat. I'm curious to know if the nursing homes have received their mailing yet. I know I've heard from Kendra at Riverside that they have gotten theirs, but I really haven't heard anything else from anyone else. So I'm hoping that you'll let us know, and also let us know how you're using it or when you plan to use it. We think it's pretty exciting. So the next part of our webinar is the fun part. It's the data review. We'll be reviewing the data for the hospitals and the nursing homes and the initiative, the baseline time frame calendar year 2015. This is actually going to be done by Jennifer Chang, our data analyst, and many of you have heard her before on these webinars and other webinars if you're a hospital. She was also the analyst for our HAI improvement network for hospitals. So Jennifer, the floor is yours.
Thanks, Deb. So up on your screen now, you can see a list of the measures that were provided in the baseline report that we sent out a couple weeks ago. And if you have not yet set up your account, we'll be reviewing the details later in the presentation, so just hold tight. So you can see that for the hospital measures, we included mortality, admission, and readmission rates. And for the nursing homes, we included admission, ED visits, readmission, and mortality rates for the patients sent from our participating nursing homes to the hospitals. So we're going to go ahead and start the review with the hospital measures. Next slide, please. So here you can see the basic format of how each measure will be displayed in both the baseline report and the subsequent coming quarterly reports. So we have in the table the numerator and denominator definitions for the measure, as well as the raw numbers and corresponding rates for participating hospitals, which is shown on the graph by the dotted navy blue line. And there's also a comparison for the statewide hospitals in Virginia, which is shown by the pale yellow area on the graph. So in both the table and the graph, the data are shown quarterly, except in the table, in that very right-hand column, you can see that we also included some year-end totals. So the first measure that we're looking at is all sepsis mortality, and we find that for all sepsis, the percent of patients at participating hospitals that died is at about 14.7% for calendar year 2015, which is just slightly higher than the statewide hospital mortality rate, which came in at about 13.8%. So just to provide a little background information, we identified a patient as having sepsis if any of the septicemia, sepsis, severe sepsis, or septic shock ICD-9 or ICD-10 codes were found in any of the 25 listed diagnoses on the claim. So this isn't just checking the primary diagnosis, we actually checked for the secondary diagnoses as well. So looking at that graph, one of the things we noted is that for both the participating hospitals and the statewide ones, there was a bit of a peak in Q1 of 2015 before it kind of seemed to level out for the remaining quarters. Next slide, please. So this next measure is very similar to the first one, but it limits the population that we're looking at to just the patients that had, Doug, can you go back to yeah, that one right there. So this is just the patients that had severe sepsis or septic shock. So you can see that the rate nearly doubled when we just look at this group of people to come in at about 26.3%. That means that more than 1 in 4 patients with severe sepsis or septic shock resulted in death at our participating hospitals. And again, we kind of saw that same trend where the rates seemed to be higher in that first quarter of 2015. Next slide, please. This third measure looks at the overall percent of admissions to the hospital that had sepsis. And again, we were just looking at any diagnosis position on the claim. So that came in at around 12%. So that means that around 1 in 8 of the patients admitting to our hospitals had sepsis somewhere in their diagnosis position. Next slide, please. This last hospital measure we look at is sepsis readmission rate. So out of all the patients that had sepsis at the hospitals, the percent that were readmitted anywhere. And we're finding rates of about 20%. So 1 in 5 of the patients at our participating hospitals with sepsis end up coming back and readmitting to the hospital. Next slide, please. So we next step into the nursing home measures, starting with admissions to the hospital with sepsis from participating nursing homes. So again, to provide a little bit of background, in order to presume that sepsis originated in the nursing homes, what we did is we searched for the start of a hospital claim with sepsis where the sepsis had to be present on admission within 2 days of leaving the skilled nursing facility. So of all the patients the nursing homes are admitting to the hospital, we are estimating that around 26.3%, or about 1 in 4 of them, develop sepsis at the nursing home. Next slide, please. This next measure similarly looks at the percent of patients sent from the nursing home to the emergency department with sepsis, but specifically we're looking at a group that entered the ER and then they were not admitted to the hospital. So as you all could probably anticipate, overall just the raw numbers and the rates are lower than what we saw for admissions. We had just 4.5% of these folks indicated as having sepsis. And that's probably due to the fact that in a lot of cases, if they came to the ER with sepsis, they were subsequently admitted, and then they end up counting towards our admission group rather than this ED visit only group here. Next slide, please. So this next measure looks at the percent of patients that were discharged from the hospital with sepsis to our participating nursing homes and readmitted within 30 days. So here, this rate is around 24.6%. So again, about 1 in 4 patients, which is we found is notably higher than the readmission rate for hospitals that did not specify discharge destination. So if you recall, when we were looking at the hospital measures, the readmission one came in at around 20% of patients with sepsis discharged anywhere were readmitted, whereas here we were just specifically looking at those patients that were discharged from the hospital to a nursing home, and that percent being 25% is notably higher than when we looked at all discharge destinations. Next slide, please. And finally, this last measure looks at the percent of transfers to the hospital from our nursing homes with sepsis that resulted in death. So here, this rate is coming in at about 20% for calendar year 2015, indicating that about 1 in 5 of these nursing home residents that presumably developed sepsis at the nursing home and got sent to the hospital resulted in death. So if you recall, again, back to our earlier hospital measures, the hospital mortality rate for all sepsis was around 15%. So again, we're seeing that the patients developing sepsis at the nursing home and going to the hospital are more likely to result in death than the general population that just has sepsis at the hospitals. So kind of consistently, we're seeing a bit of a higher rate when we're looking at specifically just the population that are going from the nursing homes to the hospitals. So that's why we're really focusing our efforts on the nursing homes and the hospitals working together here. So hopefully these baseline reports will help you all start thinking about how to focus your efforts in stopping sepsis in your facilities. And this actually concludes our data review. So Jason, do you think we could open the line to see if anybody has any questions on the data review before we move on with the presentation?
Thank you. Once again, if you'd like to ask a question, please press star then 1 on your touch-tone phone. Once again, that's star 1 on your touch-tone phone for a question or comment.
And while you all think about some questions, I see in the chat that Renata has asked about when 2016 data will be available. So we actually have data through quarter 3 of 2016 right now. But since we're kind of just getting started in the initiative and the baseline time frame is calendar 2015, we started out just sending out these reports. But we can go ahead and begin sending out quarterly reports for 2016 starting in April.
Oops, I was on mute. Jennifer, this is Deb. And how can they get their data reports?
You can receive their data reports by signing up for Box, and we will go ahead and be dropping those into Box, and when that happens, Box will notify you with an email letting you know the name of the file that has been received in your account.
Thank you.
Jason, do we have any questions in queue?
We do not have any questions at this time.
So this is your chance right now, everybody. We have Jennifer on the line. You can talk to her in person, no emailing back and forth. Any questions that you may have about the data that she's just reported, it's very interesting. It'll be nice to see, you know, as we move forward, what the difference is, of course, in 2016, but then definitely once we start collecting our data for this project, how things are going to get better through that.
I see that Wanda has already answered the question in the chat about a Box prompt to update our data. And I did want to specify that in the baseline reports and in the coming quarterly reports, some of the background information that I covered in our data review today should be provided as a kind of supplemental information document that comes with your report. So if you have any questions about how exactly the measures are calculated, hopefully that supplemental information will answer some of those questions. But if you have anything further that were not answered, you can go ahead and email me, Deb, Wanda, Candy, etc.
And we did have a question coming over the line from Debbie Thomas from Central Health.
Hi. I just had a question about accessing Box. We've not been able to access it for either of our 3 facilities here at Centra. I don't know, I've put out a call to our security folks. I think it's getting blocked on our end. But is that the only application you can use to send us our data?
So this is Deb, and it's the secure way that we're using to send this data. If we have totally gone through everything else and was trying to troubleshoot with you, we'll have to come up with a different way. So what needs to happen is that your IT department needs to allow this website, because there are some that they disallow and allow, just like you do with your normal at-home computers. So have you actually talked to them about allowing it?
I have been in contact with them by email, but I've not gotten a response yet.
Okay, so that's what they need to do. I don't know if there's some way that we can help you in getting them to answer you. We can maybe get an email together that you can send off to them explaining it. That might help. It's just another tool. But we've used this successfully in other projects, and getting it up and going because of some of the firewalls in the facilities is but sometimes a problem. But once we get over that, it works really well, and everybody loves it because you have immediate access to your data.
Okay.
So it's well worth trying to work with them. So offline, let us know what we can do to help you kind of just put a bug under them.
Thank you.
So is there anybody out there who's successfully been able to get into their box? Can you get on the line?
Once again, to queue up, it's *1. Okay, and we have Kendra Cooper from Riverside Health System.
Hi, Kendra.
Hi there. I was able to get in.
And so once you were able to get in, can you let everybody know how user-friendly it is or isn't, if you don't think it is? But and Kendra, you're really a little bit unique where you have multiple facilities, both nursing home and hospitals, to cover.
It is user-friendly. I did have a little problem with the password initially. Once I went to accept each of our nursing facilities, it asked for a new password, but somehow it has cleared up and I'm able to get to all the reports. So outside of that initial hiccup, yes, it's easy.
All right.
For the other Riverside team members, I'll be getting those out to you shortly.
Yeah, so it's well worth the time involved in the beginning, and, I understand that it is a little bit, when you have to contact IT, that's just an extra step there that does take up a little more time, so I appreciate that y'all try that. And then get back to us if that doesn't work.
Deb, this is Wanda. There was a comment in chat that one participant thought the invitation was spam and so deleted it. And I just wanted to comment that HQI will be reviewing the acceptance of invitations weekly so that those who have not activated their account, a new invitation will be sent.
I will say it was somewhat confusing. We had one from a Sarah Studebaker and then a Linda Harris.
Yes, and that was actually sent out in the box instructions that we sent out ahead of time. So hopefully the instructions got there before the invite did. The initial invite came from Sarah Helen Studebaker, and then each week Linda Harris will be going in, because what happens with those invites is that's okay to the person who deleted it, because you're going to be getting more, Jeremiah. Once a week goes by, that invite is no longer valid. So it needs to be sent out again. So we have Linda Harris working with this to send out invites to everybody who has not already signed up to Box. So you will be getting an invite to Box. If you don't accept it and sign in, you'll be getting that invite once a week. So you'll be able to, you can't go back and look for the previous one. That is a bit of an issue with Box, and we found that out using it for the HAI Improvement Network last year. Any questions about that? So we basically covered this next slide. Does anybody else have any questions about the data or any questions about Box? So we just discussed how it's replacing the secure files, so you no longer need to get an encrypted email. You'll receive the link, the first one from Sarah Helen. Every 7 days you'll get another one from Linda. And this is just to let you know that if you're having trouble accessing your Box, like, we were just told that that Debbie was having trouble getting in because their system wasn't allowing it. Sarah Helen is the person that you can call or email at HQI to troubleshoot that part of it, because she has access to our IT department and they can work together with you. If you have any questions about your data report, you can, for the hospitals, get a hold of Wanda, and there's her phone number and her email, or for the nursing home, you can get a hold of me, and there's my phone number and email. And then Jennifer Chang, will you put your email and phone number in chat, because I forgot to put that on here, because Jennifer can answer some of your questions too.
Sure, Deb, I'll go ahead and do that.
Thank you. So I'm going to turn it over to Rhonda right now to discuss the hospital project timelines and needs. Rhonda?
Great. Thank you, Deb. So the next hospital webinar is scheduled for Tuesday, March 21st from 11 to 12. And Kathleen Lohman, the sepsis content expert that we're working with, will join me as we present universal lessons, best practices, and have an opportunity for a Q&A. I know with some of the new guidelines that have come out, there are some questions related to abstracting and some of the measures. So we will allow time for that, as well as having an opportunity to review the process and form for uploading your performance measure data into Box. The invitation to this webinar will be sent out later today. So I look forward to seeing lots of acceptances of that. Moving on to the sepsis process measure. Deb, you could go on to the next slide, please. So the process measure template, as we discussed, will be sent to you this week. You will be asked to complete the template and upload it to your Box account. I will include instructions for the completion as well as the uploading of that template. We have a couple of small changes. You will have the choice of submitting your data monthly or quarterly. As you know, you will get the most benefit from this work by submitting the data monthly and utilizing more timely data, but we understand some of the constraints that facilities are working under. So we'll be working on that as we go through the project going forward. You could go on to the next slide. Okay, and then we will be preparing for hospital site visits. So for those of you who have not yet completed your gap analysis, please do so as soon as possible. I am contacting hospitals this week that have submitted their gap analysis and policies, and I am scheduling site visits. During these visits, I will meet with your sepsis team, or ask to meet with your sepsis team to review the completed analysis and your data submission and policy submission, and also discuss specific facility project aims for process improvement. So I think it'll be a helpful meeting to pull this project work together. And with that, I am going to turn the presentation back to Deb.
So if you have any questions about that for Wanda, just put it in chat, or we're going to open up the lines one more time at the end of this presentation. So for the nursing home, we are having our calls on the fourth Tuesday of each month, and then quarterly that's going to coincide with the hospital calls so that we can review data together. If you have any comments or suggestions for topics for the calls moving forward, we'd be happy to incorporate them, or if you think that there's a different format we should be using, we're open to that too. There'll be some regional calls moving forward in the future once we've gotten through our infection prevention assessments, and possibly even some face-to-face events that we've been talking about, whether they'd be just within nursing homes or if they'd be within nursing homes and the hospitals together. So that being said, for the nursing homes, today when I sent out your handout for this webinar, I also included again the link for the team contact list and the baseline infection prevention assessment link. So anybody who has not already filled that out, please take the time to do it. The team contact list, those names you should have together and easy to incorporate in there. And then as far as the baseline infection prevention assessment, just go through and answer it to the best of your ability, just right off the top of your head. You don't have to research anything. There is a an unknown answer. So I don't anticipate that that should take much more than 15 minutes of your time. I know everybody's time is valuable, and I'm not one that wants to be taking these assessments either, but it's really going to be helpful for us moving forward to identify some of the needs with this project. So for nursing homes, we've got the data submission too, and that will be submitted through Box. Along with your handout today, I did send the sample of the template for the data reporting that you'll be doing. It will be uploaded into Box, so it's really important for us to get you all onto Box because the data reporting started in January, so you may have to backtrack just a little. Any specific questions about those measures, please let us know. What we found is that facilities collect data just a little bit differently, but the really important part of this is that you are consistent throughout the whole project. So what you start collecting, you continue to collect so that we can see how you're trending. And we talked a little bit about the toolkit. So the beginning of the toolkit should have been mailed out to you. There'll be future additions to that, and eventually a thumb drive that'll have everything on there. We are putting together a video, which we're kind of excited about, that you'll be able to use to see how to use the tools. So if you have not received your toolkit yet, you can let us know, or you can contact Rhonda Fletcher. Her phone number and her email are on here because Rhonda was the person at HQI who sent the toolkit to you. And this is what's going to be in the toolkit: the CN Sepsis 100 pocket card, rapid identification tools, sepsis algorithm for nursing homes, and the patient resident flyer that was mentioned earlier in the presentation. So our next webinar is March 28th. Please mark your calendars. We will send out a save the date also. This is for nursing homes I'm talking about, 11 to 12. So like I said, I will send out a save the date. If you have any suggestions, please let me know. We're hoping to be able to show you that using the tools video at that point. So we are to the question and answer part, and we have 5 minutes left. So Jason, would you please open up the lines again?
As a reminder, if you have a question or a comment, please press star 1 on your touch-tone phone.
And while we're waiting, I thought I saw that the evaluation popped up at one point, so if you could complete that evaluation before you sign off also. And also, while we're waiting, I was trying to quickly look back through the chat. Wanda, do we have anything that wasn't answered in chat? That's a great idea when I saw that thing about the spam, to put HQI first. Thank you. Those kind of things, you know, sometimes we don't think about it, but we're happy to take your suggestions.
I think we covered everything that came through in the chat. I do want to just make one point. Earlier when we were preparing for this project, Deb and I thought that we would host the nursing home specific and the hospital specific webinars on the same day, but because some hospitals have both nursing home and hospitals in their systems, or they would like to listen to the nursing home presentation as well, or vice versa, the hospital one, we will be hosting those on different dates. So in March, the hospital presentation will be on March 21st, and for the nursing homes, it'll be March 28th. Both Tuesdays and the same time. Just one will be the third week, the hospital, and the nursing home the fourth week.
Yeah, thank you. That gives Rhonda and I also the opportunity to be on each other's webinars.
Yes. Mm-hmm.
And go ahead.
Oh, I just see Kendra's note. Yes, we are going to send out a calendar invite for the year to help you plan ahead. So, yeah, we'll get that out shortly.
And beat sharing calls, Kendra, there are no CEUs available. We're not sure about moving forward if we have any face-to-face events yet. So any other questions? Jason, anybody on the line?
I haven't had anyone come into the queue.
Okay, it has been a quiet bunch today. It's Monday. Happy Monday, right? We're all trying to get going with our work week. So thank you all, and I hope that you have a really wonderful rest of your day. You're getting a whole 2 minutes back from us. Thank you.
Thank you, ladies and gentlemen. This concludes today's webinar. Thank you for your participation. You may now disconnect.